Welcome back, listeners. Today I have a returning guest, Dr. Dawn Teater. Dawn is a pain and addiction specialist. And if you have not heard the previous podcasts I've done with Dawn, I would really encourage you to go listen to those. There are 3 of them, I believe. They're titled Alternative Pain Treatments, Stigma Associated with Addiction, and Trauma and Predisposition to Pain and Addiction. They were great recordings. Today, we're going to talk about buprenorphine. But before we do, let's back it up just a little bit. Well, first, let me say welcome, Dawn, welcome back. So let's start with the very basics. Give us an overview of what happens to the brain after it is exposed to opioids.
Okay, so I think this is really important information that I share with medical professionals as I talk with them, and that's that opioids cause changes to our central nervous system and probably to our peripheral nervous system as well. But in particular, with the central nervous system, studies have shown after the very first dose, the brain starts to make changes to compensate for the opioids effects, and some of those changes end up being permanent. And so we've seen that even after getting a dose of fentanyl during surgery, while people are basically asleep, they give them fentanyl to have them respond less to the pain that occurs when they're unconscious. But even doing that results in more pain sensations after surgery than people that don't get fentanyl. And that's because the brain, the central nervous system, begins to respond to that first dose by doing several things. One is it reduces the number of endorphins it's producing. The opioid receptors that normally are receiving our opioids and our endorphins, some of them go underneath the surface and become inactive. And so it makes it so the brain is less responsive to our own opioid system. Plus there's a lot of other changes that happen as well. But these changes occur in a way that make people feel pain more. The other thing they do is those first opioids, as people get them, they are flooding the opioid receptor in a way and activating it the way endorphins normally do, but to a much higher level. And our endorphins do several things, but one of them is reduce our sensation of pain to some degree. But even more so, they give people this warm, comfortable, confident, happy feeling that is a wonderful feeling. Some people describe it as a high. Other people say, it maybe brings them up to what normal is if they've had a really hard life. So the very first dose can start to make changes, and the longer people are on those doses, the more those changes occur, the more they become permanent and hard to reverse. So we see people that, many studies have shown this, and probably most of your people watching this are associated with it, but, a 6 or 7 day course of an opioid results in a 5 to 7% chance that the person's going to remain on opioids long term. And a 1 month prescription of an opioid, if people take opioids for a month, those changes become so significant that at least a third of people end up on opioids long term because of those changes that have occurred. And we know that in some people, those changes can start to reverse some. When I was in medical school, we were taught that your brain changes until you are about 26. And by that point, it kind of gets set. And there's no changes that occur after that. We now know that the brain does change, the central nervous system pathways change, the neuroreceptors change all the time based on our environment and what our brain is exposed to. So we are able to reverse some of those changes in some people, but in many people, those changes don't go back to normal. And so these people are left in a state where they are endorphin deficient. They don't have the amount of endorphins they need. Their opioid receptors are markedly diminished. And so they don't get the benefit of that endorphin system that operates in most of our brains. And again, the purpose of that system is to help us feel kind of warm, comfortable, happy, confident, motivated. I call it our success system because it gives us a lot of these characteristics that lead to being successful. Being able to go to work and work with colleagues and having a good home life, all those kind of things. If that system isn't working, then you tend to feel depressed. You feel isolated. You feel lonely. You feel just kind of miserable, basically. And so if that system has become damaged and these people are like this, it's a really horrible way to live. And then, we give them an opioid or they take one from a friend, and it kind of corrects that, temporarily corrects that. So in many of my patients, they say, I took that opioid dose and I felt normal again for the first time in a long time. So that's kind of where buprenorphine and methadone come into play for these folks. Is these folks that have been on opioids a long time, they just can't succeed. They can't live. They can't be happy without something helping them out.
Yeah. How do you explain the difference between somebody that has a true substance use disorder, it just changes their life, like they just, need to have something, versus somebody who's been on chronic opioids but doesn't exhibit those types of behaviors? I mean, they're in pain, and so they need it. Now we can talk about, the increased pain receptors and whether there's an issue there. But as far as it doesn't drive their emotional, do you know what I'm trying to say?
Mm-hmm.
Like, how do you explain the difference between what is happening?
Yeah, so some of it is just the existence of the availability of their opioid. So if their doctor's prescribing it and they can pick it up at the pharmacy all the time, it's helping to compensate for some of those changes. And in those people, a lot of those people, there's a term we're using now called complex persistent opioid dependence, meaning they don't really meet the criteria for opioid use disorder. They're not craving them so much, they're not going out and buying them on the street, but they also can't stop taking them. Even if their painful problem, whatever it is, has gotten better and is healed up, their brain still needs those, and they just really can't come off them without getting many of these symptoms that I described. And so you try to reduce the dose, and as you reduce the dose or taper them off, they do get some of that craving, and they really do need it. They get more depressed. They feel pain more. They think they just absolutely can't stop it. And these are people that, you just can't taper them off. You try, but you can't be successful without making them miserable. And the current thinking for complex persistent opioid dependence is, it happens in most people that are on chronic opioid therapy for, considerable amount of time, a month or more. And again, for those people, it just gets really hard to take them off. And, the current thinking is buprenorphine is the treatment for them as well, to kind of fill up those opioid receptors that are there and return them to feeling normal again.
Okay. So even if they don't feel like they're dependent on it, I just still have pain. I have to take it because of my pain. If you could miraculously make the pain go away and then took them off, tapered them off, they would find that they had more issues than they thought they were going to.
Right. And even the start of the taper sometimes, that first dose reduction, they're on 60 morphine milliequivalents a day, and you cut them down to 45 or to 50, and, they feel more pain. They just feel miserable in many ways. They don't have the motivation to keep trying this. They just want more of their medicine. They say, I just can't do this. I couldn't cut it down. It was just intolerable, and you need to go back up on the dose. So it can start early. It can happen further down as you go down. Studies have shown that it doesn't happen with everybody, but, probably most people. Studies have shown if you can successfully taper people off of their chronic opioid therapy, most people feel less pain. And that's because of that opioid hyperalgesia that occurred while they're on it. So, again, these people that are on these doses, 40, 50, 60 morphine milliequivalents a day or higher, it's worthwhile to try to taper them off. But if they can't do it, we really need to listen to them, and we need to figure out, what's going on and what else we can do to help them out. And,
yeah. Okay.
I feel sympathy for them. It's hard to do. Their pain does get worse. But we need to find an answer. And again, oftentimes buprenorphine is that answer.
Okay. All right. So there's two, I hear you saying buprenorphine can also address their pain. So that is one thing. So I do want to talk about that. But then there's also the buprenorphine for those that aren't in pain and are now just continuing to take it to feed that substance use disorder, right? Mm-hmm. So let's talk about that for the substance use disorder first. And I want to hear your thoughts on abstinence versus straight to buprenorphine. Do you try one over the other? What are your thoughts?
So studies have shown that people that even do a residential abstinence-based program where they go in and taper off, they have, a residential situation where they have therapists seeing them every day and they're with other people and they're with groups, stuff like that. Studies have shown that people that go through a program like that have a higher risk of dying than people that get no treatment at all. So I think it's certainly something we need to question. And that's because they come out of these programs and they are now abstinent, but their brain is still lacking all these endorphins. They're feeling miserable and they start taking them again and they overdose. And the risk of overdose is higher than if they got no treatment at all. So, I think for some people, you can do that. I think it needs to be very carefully done. I think you need to be talking with them. I think you need to be ready to give them buprenorphine if necessary, because you don't want to just have them go through that abstinence-based treatment, being told that that's the only treatment they can get, and then, ending up and going out and overdosing. It does work in some people. There are a few people, we don't know what that percentage is, but it's probably fairly small, people that can go through an abstinence-based treatment and be successful, maybe 20% or so. I use 20% because that's about the number of people that get into a methadone program or a buprenorphine program that can ultimately come off of it later on. Okay. So there are some people, they need to be really highly motivated. They need to have a really strong support system. And they need to be really carefully monitored. Almost none of my patients in addiction treatment have that. Most of them, their families are also using drugs. They've got no support system. They've got little education. They have a hard time finding work. Life is really hard for them. Those people are not going to be successful tapering off in most instances. So we need to be aware of that, as opposed to, say, the airline pilot who has a family that loves them. He has a support system, through the Pilots Association to do this. And they're in a highly monitored program. They've got a lot of motivation to do this and come off. They might be more successful, but they still might not. So, again, you work with them. If they just can't do it, they need to be put on medications. But if they can, then great for them. I will comment, there was an article many years ago looking at Vietnam veterans. And I don't remember the exact statistics because it's been a while since I've read this article now, but as I recall, they believed about 1 out of 10 of the vets of the soldiers in Vietnam became addicted to heroin while they were there. And so there was this concern as the Vietnam War was ending, and they had these tens of thousands of soldiers coming back, where there'd be thousands and thousands of them addicted to heroin, that suddenly, we're going to have this problem back at home. But they found that by getting out of the wartime situation, by coming back to their family, by getting back to a real life, many of them were able to come off of it and do very well without medication at all. So, it is doable. But for a lot of our folks that we see with addiction, that's not the situation. They can't completely change their environment. They can't suddenly become educated. They can't suddenly get a good job. So it's just a lot harder for those people. So again, it all needs to be individualized.
Okay.
But my experience is most of the people I see in my treatment program, they need to be on a medication and they need to start on it right away to get off of whatever they're doing.
Okay, so healthcare professionals would fall more in the possibly it could happen if, under the right circumstances, but there's not really there's a bit of a checklist you can kind of go through to rule out, this one's probably not going to be successful. This one has a chance to be successful, but they definitely need to be monitored and I guess understand that it's not a failure.
Right, exactly. Right.
Yeah. Mm-hmm. Okay. What does buprenorphine and methadone do to the brain then to combat the damage that has been done after the opioid exposure?
So basically they are filling those few opioid receptors that are remaining, and they help people feel normal. And that's really kind of the special thing about those two medications. And in particular, I think buprenorphine, and I will share, I'm obviously a buprenorphine prescriber now and I give it to people, but I've also been medical director of a couple methadone programs for probably a total of 10 years. So I treated people with methadone and it has its place as well. But buprenorphine is kind of special in that it occupies those opioid receptors and just kind of sticks on there. It has a long half-life. It stays on there for a long period of time. It blocks the effects of other opioids if people take them. People don't really feel high with it. People can get a high with buprenorphine if they inject it, but it's not a real pleasant high always, because it's often associated with some nausea and some GI symptoms if they do that. So I have never yet seen a patient come in for treatment of opioid use disorder where buprenorphine was their drug of choice. Always they'd rather have something else. That's their last choice. And there's some thought that for people that are opioid naive, if you give them buprenorphine for pain relief, because it doesn't give them that same high feeling, that it's not nearly as addicting as the others. Now, again, used long term, there might be a withdrawal syndrome, but they don't really have that high feeling that you get with it. So once people get on buprenorphine and they're taking a stable dose, they just take it every day and they just feel normal. They don't get a buzz from it. They don't feel high from it, but they do have that motivation, happiness, the ability to be with their family and enjoy time with them, that kind of thing that many others are lacking if they're in an abstinence-based program. Okay. So buprenorphine really reverses a lot of that. It doesn't reverse. It compensates for all that damage that's been done to the brain.
Okay. What are your thoughts on return to work for healthcare professionals that are on buprenorphine?
So, we don't know for sure the answer for that. We do think that people on buprenorphine don't have nearly the impairment that people on other opioids do. If they're taking whatever they're taking, there's clearly some impairment. With buprenorphine, probably not. So we don't have the studies to show that for sure, though. So, my own impression would be, I would be comfortable with primary care doctor, even a specialist doing it. Maybe not a neurosurgeon. That might not be something somebody you want on buprenorphine, but I think they could work very competently as a neurosurgical consultant. I think if there's impairment, it's very minimal. As far as airplane pilots, I'm not sure exactly what I think about that. I think that would probably generally be okay as well, to be honest with you. I think if there is impairment, it's very minimal. I do think most providers could do their job with it. I think there's maybe some situations you want to be careful or at least monitor it.
Okay. What about return to work after going through a treatment program? They're in recovery, the abstinence route.
So, again, I think that's okay, but I think they have to be really carefully monitored also, because, at any time they could return to use. And the last thing you want them doing, again, is operating or even seeing a patient, if they've returned to use, before they've had their next urine drug test and you don't know what's going on. So, I think that's probably riskier. But again, as long as it's carefully monitored, I think those people need to be monitored, need to be in a recovery program, whether it's provided by the medical association or the hospital, or whoever's doing it. They need to be in a monitored program where they are getting regular urine drug tests, where they are attending meetings, and where they are staying motivated to continue their abstinence-based treatment. People in abstinence-based programs or people that have gone through abstinence-based treatment, they're at risk of relapse 10 years later. That risk is always there. And so, again, when they're working in a hospital system or working with patients, it has to be continually monitored. And I think that does provide a little bit of motivation for them also to remain abstinent in recovery.
Sure. Yeah, I was going to ask you on the time frame. I mean, is there at some point that you feel like, okay, they're past the risk, or they're just there for the rest of their life?
I think it's there for the rest of your life. I think you just consider that. And it's, again, it's like treating any other chronic disease. It's always there. You always need to be paying attention to it. And in particular, in a healthcare field, if they have a relapse of that disease, of this particular disease, it can affect other people. So, I think it's appropriate to continue to monitor them.
Okay, that makes sense. All right, let's talk about buprenorphine for pain, to treat pain. And when we had talked before, you mentioned that back in the day, earlier in your practice, they used it for post-op pain. It was a little smidge before my clinical pharmacist time, so I don't recall this. I wasn't working with OR at that point, and you shared an article that is a recent article on the subject. So give us an overview of that article, of its use for post-op pain in particular.
Okay. So yeah, my experience being around much longer time than you, I'm sure, is that when I first got out of medical school and residency in the mid to late 1980s, buprenorphine was the opioid of choice for post-op pain. And that's because back then we did not have pulse oxes that we could use on people. And so the main risk of all the other opioids was that you overdose them and they stop breathing and they die. And, here they are in a post-op unit with 20 people and, 5 nurses or something. And people would overdose in the post-op unit, and we had some bad outcomes. So buprenorphine comes along, and all the surgeons are told this works for pain just as well as morphine does, but they won't stop breathing. So it's much, much safer. So that's what we used for a number of years. We would give them IV buprenorphine after surgery, and it did very well, reducing their pain, and they didn't overdose. And, it was a wonderful medication in the post-op unit. Now, back then, we didn't have any other way to give it other than IV. So as they got out of the IV unit or out of the post-op unit, and they were switching to oral medicines, they would switch to morphine or oxycodone because we didn't have sublingual buprenorphine back then. But then obviously sublingual buprenorphine came out, around 2000 and became used for treatment of opioid use disorder. And it kind of got that reputation that that's what it was for. And in the meantime, we got pulse oxes, and, morphine is much cheaper, I'm sure, than the brand name buprenorphine was back then. So all the hospitals switched back to morphine in the post-op unit, and we kind of got away from that. But it's very effective pain medication, very, very safe pain medication. So yeah, the article I shared with you was it looked at all the articles that had been done over the past number of years looking at using buprenorphine in the post-op unit. And that included IV buprenorphine, and it also included sublingual buprenorphine. And what it showed was that it was very effective for pain. That in fact, the conclusion was from, the meta-analysis of all these studies was that it was more effective than the other mu-opioid agonist opioids. It was more effective for pain relief. It lasted longer and it had less side effects. And so very strongly supportive of using that, again, however it is used, whether it's sublingual or IV. And I think the other thing that we don't know yet, but that we should consider is the fact that, we know that, again, that 6 to 8% of people that get opioids post-op and go home with opioids develop a long-term problem with opioids. And again, it's because of those brain changes. And it might be that buprenorphine doesn't do that the same. They're not feeling that high feeling. They're just getting pain relief afterwards. And so maybe it's less likely to cause ongoing addiction than the opioids we're currently using for post-op pain. So I think it's something that needs to be considered. It should be trialed in some places. It's a good pain medication. It appears to be a safer pain medication, maybe a better pain medication than what we're using now.
So potentially not only post-op, but continuing it for their hospital post-op stay. And then if they need something to go home on.
Exactly. And, I can even see, so, the buprenorphine patch gives you much lower serum levels than the sublingual formulations do, but still very adequate. So like the 20 microgram patch is approximately equal to about 20 milligrams of oxycodone during the day. So, you could put a patch on them when they go home and have them wear that for a week for their post-op pain relief program. Sure. And, that's something to think about. Again, we don't have a lot of, tests that have been done on this, but it's something we need to start looking at, and people need to think about starting to try. You could give the IV buprenorphine in the immediate post-op period and then transition to a patch really easily in the hospital even. That would result in less, nursing care and attention, less risk of overdoses in the hospital, and they could just continue to wear the patch as they go home and give them some pain relief.
Yeah, well, the less respiratory risk is huge.
Right. I will share with you, so I've had a bad knee and had multiple operations on it, and had my first knee replacement done about 10 years ago. And then back during COVID, that knee replacement actually broke and it had to be removed and another one put in. And for the second knee replacement, by this time I knew a lot of this stuff. So this was 5-6 years ago now. And so, this was a university hospital system. And I told them, I said, I want to do buprenorphine for post-op pain. And they said, well, we don't have it available for post-op pain here. We just can't do that. And so, I told them I wanted to do it without it. And I did. I did it with Celebrex and acetaminophen. And actually, that was adequate for me. It probably wouldn't be for everybody, but it would be nice if they had that buprenorphine option, for people that want that. For people that, have a history of addiction themselves, whether it's alcohol or tobacco or whatever it is, they're at higher risk of having addiction problems afterwards. Maybe give that as an option for them afterwards. People that have opioid use disorder, whether they are abstinent now or on buprenorphine, we should be using this more for their post-op pain.
Yeah, sometimes I've seen on people's profile both buprenorphine and an opioid, whether it's oxy or morphine. Why? When would they do that?
It doesn't make sense to me. I don't know why you would want to do that, to be real honest with you.
Okay. When we're talking about buprenorphine for first-line pain control, what would be, if, let's say that the patient continues to have pain, it doesn't take care of it, would the standard switch then to be high-dose full agonists like fentanyl to overcome buprenorphine's binding affinity? Like, what about the rebound thing to that?
Yeah.
How would that work?
So, I will just share with you what I tell surgeons for my patients that are on buprenorphine is that, first of all, buprenorphine sublingually only has about an 8-hour pain relieving effect. So even though people with addiction take it maybe once a day, for pain relief, you need to give it more often. So say they're on 24 milligrams a day and they take it all in the morning for their addiction treatment. They go in to have surgery. I recommend that they divide it up and give them 8 milligrams sublingually every 8 hours. And 8 milligrams of sublingual buprenorphine is roughly equivalent to about 200 milligrams of morphine orally. So that's a pretty strong pain relieving dose. But if they still need something beyond that for some reason, I often recommend hydromorphone because it has a similar binding affinity to the opioid receptor, and it's probably stronger than the fentanyl is. So I recommend hydromorphone, either IV or PO, whatever they need to do, as an add-on to that if they need to give something additional for pain.
Okay.
And,
so
it can be quite effective.
Okay. All right. That was going to be my next question. Does this work in those that have an opioid use disorder and are already on high doses of buprenorphine?
Yes, it does. Mm-hmm. Yes.
Okay. All right. Well, I want to encourage the listeners to, take this information back to your opioid stewardship committees for review. I can tell you that when Don and I first met, it was because we were doing some education at a facility that I worked at, and he came to talk about opioid alternatives for pain relief, similar to what he did for his knee surgery, is a combination of acetaminophen and ibuprofen. And I think you gave that talk maybe 5 times in 3 days, maybe a little bit more than that, to various audiences, including several physicians. And as a result of all of that education, the facility where I was working was able to decrease opioid prescribing, not to the point, where it hurt patients, but just judicious prescribing. They decreased opioid prescribing by 50%. So it made a huge difference because we're talking about that, that first exposure, right? Everyone's going to have a first exposure. And so how can we reduce that first exposure? So, take it back to your committees and have this discussion. There are things that maybe we can do up front for your patients. And, we focus on the healthcare professional, but sometimes the healthcare professional is the patient, right?
Right. I will also comment, you and I talked about this the other day, and, hopefully things will develop in the future where hospitals are using more buprenorphine first line for their acute postoperative pain and have that more available. When you're talking about diversion in the hospital, there will be much less diversion of buprenorphine, again, because people don't get that high feeling from it than maybe what happens with other things. So, it might be a safer opioid to have available on hospital units for hospital staff, less incentive for them to divert anything. So, that might be something in the future that we talk more about, but just something to think about. I think that's kind of an interesting thought.
Sure, absolutely. When you've got every patient coming out of the OR on, fentanyl or hydromorphone, if you can replace that with buprenorphine, then there's not as much reason for nurses in particular to put their hands on that medication. So, yeah, good point. All right. Anything else that you feel is important to share on this topic?
No, I don't think so. I appreciate you having me on and talking about buprenorphine. I will share with you, and I actually talked with you about this before, but with the people listening, that I did a presentation at the American Academy of Family Physicians, and it was titled "Buprenorphine: The Miracle Medicine You're Not Using," because I do think it has a really big role both for addiction, for opioid use disorder, and for pain that's not being used now. And I really think it's just an extremely important medication that just is not getting the credit it deserves, and is not being utilized as much as it should be. And I hope we're able to change that in the next few years.
Yeah, definitely something to think about. All right. Thank you very much for your time, Don.
My pleasure. Thanks for having me. Bye, Terry.
Bye.